Good evening and warm greetings of Merry Christmas season to one and all. Friends, Mahahappy Women Committee is extremely delighted to welcome you all in our very last and very popular online Wednesday Wisdom program. Children are not small adults. Their physiology, their pathology, and along with treatment differs. Pediatric surgery plays a critical role in addressing surgical needs in children from neonate till adolescence. I, Dr. Manjusha Sherkar, Chairperson Women Committee MAHAIP 2024, welcome today's esteemed expert faculty, Dr. Rasik Shah sir and Dr. Mandar Vaidya sir of the Specialty Chapter of Pediatric Surgery. I welcome our MAHAIP President Dr. Ram Gopal sir, Honorary Secretary General, Central IIP EB Dr. Amol Pawar sir. I also welcome today's young talented speakers from all over Maharashtra, from all 5 zones of Maharashtra, Dr. Ashwini Khanolkar, Dr. Swati Sulakshane, Dr. Prashant Badane Patil sir, Dr. Vidyananda Deshpande and Dr. Usha Gajbhe. I welcome today's MMC observer Dr. Nilesh Ahir, HOD Department GMC Nasik as a MMC observer for today's webinar. I welcome all the esteemed EBs, OBs and delegates of Central and State IIP. Friends, let's make few minutes to express our deep gratitude towards our MAHAIP mentors for bestowing faith on this committee to work successfully over last 365 days, and it's our honor and privilege that CIP has declared MAHAIP as a best branch of year 2024. Thanks all the MAHAIP members for your valued inputs and unmatched support, especially my Women Committee office bearers, Dr. Grivita Raikar, being my co-chairperson, Dr. Amruta Baviskar, Women Committee convener, Dr. Smita Bajaj, Dr. Prachi Birari, Dr. Amruta Shirodkar, Dr. Jayashri Deshpande, Dr. Lakshmi Kadu, Dr. Anju Kadu, Dr. Swapnali Dhoka, Dr. Kashmiri Badbade. Dear all, your active participation gave this committee a grand success in the form of name, fame, and great academic feast learning over last 2024 year. I can't forget the past chairpersons of Women Committee, my dear friend Dr. Renu Boralkar and Dr. Sonali Shirbate, setting the success bar very high in terms of academics in year 2022 and 23, respectively. I like to mention the efforts of dynamic personality Dr. Amol Pawar, who has thought of starting this Women Committee in year 2024. Dr. Ramakant Patil sir and Dr. Hemant Gangolia supported us. We could shoulder the responsibility with the finest guidance by our Dr. Ram Gopal sir, President sir, and Dr. Amol Pawar sir. Dr. Bhavesh Mithya is a brain behind scientific drafting of the topics along with our Women Committee members. Friends, pardon me for this extra time, but I can't stop myself from expressing the gratitude being this last. Actually, we are overwhelmed and we are so feeling so accomplished and joyful to run this committee. And I'm so happy and so grateful to the entire MAHAIP. Thanks a lot. Now I request our respected President, sir, Dr. Ram Gopal Chajera, to say a few words.
Good evening, friends, and welcome to the last episode or last session of Wednesday Wisdom for the year 2025. We are happy that the incoming president, Dr. Sanjay Pakmode, will continue all the sessions, though the committee will change. Am I audible?
Yes, sir.
Yes,
Yes, sir. You are.
We had started our year with the Wednesday Wisdom, and we are ending our tenure with the Wednesday Wisdom. And I really appreciate the work, tremendous work, I should say, done by the Women's Committee, led by Dr. Manjusha Sherkar and co-chairperson Dr. Gravita Raikar, equally supported by the convener Dr. Amruta Bhaviskar, plus all the committee members and EB members of Women Committee. I appreciate every time they have done a hard work to select the speakers, to help the speakers in preparation of the slides, and before presenting to you, they had behind the scene They had seen the slides, correction, timing, everything. So a great work done by the Women's Committee. I really salute and appreciate. Now, friends, we have covered a lot of topics. This time we would be covering pediatric surgery, which is a very important part of the pediatric practice. I welcome today's experts, Dr. Rashid Shah sir, pediatric surgeon from Mumbai, and Dr. Mandar Vaidya sir from pediatric surgeon from the Nashik. I also I wish best of luck to all the presenter today, Dr. Ashwini, Dr. Swati, Dr. Prashant, Dr. Vidyanand, and Dr. Usha. Welcome all. Over to you, madam.
Thank you so much, sir, for your rock support all the time and fine guidance. Thank you so much. And I request everyone that you all should write your name, MMC registration number, and CIP number, since MMC has given MMC point for this webinar. So don't forget that. And all these efforts goes with Dr. Amol Pawar sir's efforts. He is continuously behind an entire year. He has worked so tireless, and nothing than that is a major support for us. So I request Dr. Amol Pawar sir to say a few words.
Thank you, Manjusha ma'am, for your kind words. First of all, welcome to Dr. Ram Gopal Chezara sir, current President Maharashtra IIP, then Dr. Sanjay Pakmude sir, President-elect of Maharashtra IIP, then today's experts, Dr. Asik Shah sir from Senior Pediatric Surgeon from Mumbai, and Dr. Mandar Vaidya sir, who is Senior Pediatric Surgeon from my own city, Nasik, and also our speakers, Dr. Ashwini from Mumbai, from Navi Mumbai actually. Then in flyer it is wrongly put as Mumbai, but in message it is Navi Mumbai. Then Dr. Swati Sulakshane, she is from Pune. Then Dr. Prashant Badane again from Nasik. Dr. Vidyanand Deshpande from Chhatrapati Sambhajinagar, and Dr. Usha Gajbiye from Amravati. So welcome to all of you. Then again, I welcome all executive board members. Dr. Mateen Sheikh has joined. Then many others might have joined. Then all the office bearers of different Maharashtra IIP city and district branches, all delegates, PG students. So as already I was to take all these names which Dr. Manjusha ma'am has taken. I know them by heart because they have consented to Maharashtra IIP when we called them in last December. So Dr. Anju Kadu ma'am from Nagpur, then Dr. Lakshmi from Amravati, Dr. Swati, Dr. Smita ma'am from Aurangabad, Dr. Swapna Nune from Nanded, Dr. Prachi from Nasik, Dr. Rushali from Jalgaon, Dr. Amruta Shirodkar from Mumbai, Dr. Jayashree Deshpande ma'am from Palghar, Dr. Swapnali Dhoka from Pune, and Dr. Kashmiri Badbade from Kolhapur Ichalkaranji. So these were the pillars of Maharashtra IIP Women Committee, and they they worked under the guidance of none other than Dr. Manjusha Sherkar from Aurangabad. She was the chairperson. Then Dr. Grivita Raikar from Thane, and she was co-chairperson, and Dr. Amruta Bhaviskar, she's convener. So they all have worked very hard in the success of all these 10 programs of Wednesday Wisdom. Actually, 2 years back, it all started with Dr. Enu Boralkar. She just lost her elections, and she wanted to do something for Maharashtra IIP. And then she was put into executive board member along with Dr. Sonali Shirbate. So senior amongst them, Dr. Renu became chairperson, and the junior, Dr. Sonali Shirbate, she became co-chairperson. And then we thought of this program, and then why not to motivate the young speakers to come on the Maharashtra IIP platform, because in conferences, many of them doesn't get the opportunity because there are many senior stalwarts who are academicians and who have worked for Maharashtra IIP, and they are very known faculties all over the conferences. So we wanted to cultivate these young chaps, and Dr. Renu ma'am, Dr. Sonali ma'am, and others who were the zonal executive board members from all the 5 zones of Maharashtra, Mumbai, North Maharashtra, then Mumbai Konkan, North Maharashtra, Western Maharashtra, then Marathwada and Vidarbha. They all have worked. And first 2 years, the program was called as Tuesday Takes. So next year, Dr. Sonali Shirbate and Dr. Neha Singh, who was co-chairperson last year, they also worked very hard, and convener was Dr. Manjusha ma'am. And this almost, I think, in 10 into 5 are 50. And last year, I think 11 programs were there. And previous to that year, 11 programs. So I think almost 110 and this 160 speakers were introduced to Maharashtra IIP members. Various topics were given to them. This year, Dr. Bhavish Mithia, he has taken all the efforts in putting various topics, various subtopics of various on various subspecialties, and he has really very worked very hard. Various interesting uh, subspecialties, various interesting topics he has given to us, and then in other programs also, he has helped us a lot in coming out to with various topics. So grand salute to Dr. Bhavesh Mithia, who was the scientific chairperson. Then all the executive board members from various parts of Maharashtra, they worked very hard for the success of Maharashtra IIP program. Then along with them, Central IIP, Dr. Basavaraja sir, Dr. Vasant Kaletkar sir, Dr. Upendra sir, and many others, Dr. Dynamic Secretary, Dr. Yogesh Parikh, Atanu Badra, and all the executive board members from Maharashtra. This year, they helped us in bringing out of these faculties and very scientific programs under Maharashtra IIP. And already Manjusha ma'am has told, Maharashtra IIP has got successfully third time. This is hat trick. Never happened before. We got the first prize in at national level, and already in just now we finished Maharashtra IIP sports. Almost 9 to 10 district IIP members from 9 to 10 district, they came to Nasik for fourth Maha IIP sport, and Amravati bagged the winners trophy. And in national also, this we became champion 3 times, and now fourth time on 7th and 8th January at Hyderabad. The matches will go on. So it is like cricket is, we are following cricket. Academic is following sport. So in sports, we already bagged 3 trophies at Kochi, and now in Hyderabad we'll be bringing third consecutive first prize for academics or for year-round activities at central IP level. So I thank all the office bearers of district, city branches who have worked very hard in celebrating these IIP weeks and days under their branch and under Maharashtra IIP banner. And because of their efforts, we got this first prize. So I think I have covered almost all the
Everything.
this thing what I wanted to tell you at the last. And I thank Dr. Sanjay Pakmode sir that he has consented to continue these programs, and will be moving ahead next year again with some interesting uh, academics and other activities IIP की बात community के साथ, which was started by Basavaraja sir and Vasant Kaletkar sir. So I once again welcome all of you, and I request Dr. Manjusha ma'am to take us further in this episode. Thank you. Thank you.
Thank you so
Amol,
much.
I just want to add one point to whatever you said. See, the program Wednesday Wisdom was designed by Bhavesh Mithia, but there was one program which was running in Gujarat from the Ahmedabad. They had the similar name. So we had a lot of pressure from the Gujarat to change the name of our session, but we said no, we are not going to change the name of the session. So
Yes,
that is how
yes.
the name Wednesday Wisdom continued.
That's great,
Right,
great,
sir.
sir. And we are so happy to tell that over in this year 2024, over each monthly we took one webinar, and total 50 new speakers we have given platform. Total 20 faculties guided us, and more than 3,000 delegates joined for each program in total. So I'm so happy. So now just we pardon for this time, but we can't help it. Each time we don't take so much time, but this was our gratitude. So pardon all delegates. Thank you so much. Can I ask Dr. Grivita Raikar for the further
Madam,
procedure?
before that,
Yes,
One
yes.
time,
sorry to
Dr.
interrupt.
Sanjay
I
Pakmode sir has
request
joined.
Dr. Sanjay Pakmode, who
Sanjay
is the
Pakmode, sir.
incoming
Acha
president,
sir
to
is there.
say something.
Good evening, Dr. Sanjay Pakmode sir.
Sir, sir,
Am I
please.
audible? Good evening.
Yes,
Yes, good
audible,
evening,
sir.
sir. Welcome to our Wednesday Wisdom session,
Thank you,
sir.
ma'am.
After
Thank you,
exam.
ma'am. Thank you, ma'am.
Yeah.
Wishing you a very Merry Christmas and
Yes.
congratulating Ram Gopal sir and Amol for consecutively winning the third prize at the national level. And they definitely deserve this award because I have seen the Amol secretaryship since last 3 years. The way he was working, nowadays I call him Murlela secretary. So I am happy he is also continuing with me as a secretary in my tenure. So I am rather confident in my tenure. I'll get a lot of advice from him how the whole year will be doing at the best, as the three people have already taken this Maha IP to the greater heights. So again, to achieve the newer milestone, what we can do, that we'll definitely try from our side. And even in the sports, as Amol has said, they are doing very well. So definitely this time also, again, Maharashtra is going to do the very well, because I have seen in the last 2 years matches the way Maharashtra plays. So that is, they are unbeatable. So definitely Hyderabad, they are going to win it. So in the academics as well as in the sport, Maharashtra is a very front runner, both in the sports as well as the academics. So good on the national levels, we are at the first, and at the both the levels. And again, the way Sir Ram Gopal, under the presidency of Ram Gopal sir, they have conducted the program. I have gone through all the 3-4 presidents, what they have taken the programs, and I found them, they were doing the very wonderful programs. And if I have to do something newer, or definitely there are a few programs which can be carried forward, because hardly they need the way the journal journey I was told. So I already prepared for the first journal journey, because it is coming on the 1st Jan. So journal journey will be continued on the 1st Jan, very first day of the this 25. Which were done in the
Very
last 3-4 years, which were very wonderful, where Amol was also involved. So I think it will be very possible for me to conduct and continue those programs. And in addition to that, if we'll see, our scientific chairperson adds a new vision to it and puts the new programs in it. So again, I welcome Mandar Vaidya sir and Rasik Shah sir and all the younger people, younger dynamic people who are presenting the today's cases. Thank you. Thank you. Thank you for giving me time. Manjusha ma'am, you have done your women's wing under your chairmanship, have done the wonderful thing. So again, congratulations to you also. Thank you.
Thank you, sir, for your blessings and looking forward for you. Congratulations, being a Maha IP President 2025, sir. Thank you so much. Yeah. I request Dr. Grivita Raikar, my co-host, co-chairperson of Women Committee, to take a mic for further proceedings. Dr. Grivita, are you there? Let's start with the introduction of today's speakers. Today's expert faculty. Pallavi ma'am, can I have a CV slide of Dr. Rasik Shah? Doctor, we are so fortunate to get expert Dr. Rasik Shah sir. He is a senior pediatric surgeon. He is a head department of surgery and senior pediatric surgeon, SRCC Children Hospital, managed by Narayana Health. Sir is pioneer in minimal access pediatric surgery, pediatric oncosurgery, and pediatric urology. He has brief achievements. Actually, sir has submitted his CV pages of 55 pages, but still these are brief lines. Sir stood first in Bombay University in MCS pediatric surgery exam and was awarded Banu Kambata Memorial Prize for the same. He had given many guest lectures, articles in peer-reviewed journals, presentations, and faculty participation in conferences. He has a dedicated YouTube channel on pediatric MAS. Sir was past president and honorary secretary of Indian Association of Pediatric Surgeons and Pediatric Endoscopic Society India section of Indian Association of Pediatric Surgeons. Sir was a course director of Institute of Minimal Access Surgery Training Center at Mumbai. We hearty welcome you, sir, as today's expert faculty, and definitely we are looking forward your fine guidance to our speakers.
Thank
Our
you.
next, yes, our next mentor is Dr. Mandar Vaidya, sir. Sir is MCH pediatric surgeon from GSMC KEMH in 1993. He's a practicing pediatric surgeon in Nasik since 1994, and he's attached as an honorary pediatric surgeon first to the municipal hospital and then to medical college hospital. Sir has done many operations on children in last 30 years. He was a chairperson of Maharashtra State Chapter of Association of Pediatric Surgeons of India last year. Hearty welcome, Dr. Mandar Vaidya, sir. And sir was very supportive in the trial run also. He has guided our speakers very well. Thank you so much. Now, let us move to the scientific session. It's already late. Can I ask our first speaker who will talk on congenital anomalies and neonatal surgeries? I invite Dr. Ashwini Khanolkar, ma'am. Ma'am, Dr. Ashwini, are you there?
Yes, I'm there.
Yes. Will you start sharing your screen? Ashwini is a
Yes.
consultant pediatric surgeon at Apollo Hospital, Navi Mumbai, and she has done her DNB, MCH, and FARES robotic surgery also. Wow, that's great. And she's an excellent orator. Let us listen from Ashwini on congenital anomalies and neonatal surgeries. Over to you, Ashwini.
Yeah. Good evening, everyone. I'm Dr. Ashwini Khanolkar. I'm consultant pediatric and neonatal surgeon at Apollo Hospitals, Navi Mumbai. Today, I will be discussing congenital anomalies and neonatal surgeries. This is just an overview. So, let's understand what are congenital anomalies. Any structural or functional conditions present at birth are congenital anomalies. Their global prevalence is around 6 to 8% of live births, and they have a leading cause of neonatal mortality and morbidity. Therefore, early diagnosis and interventions can save lives and improve outcome. I have tried to classify these congenital anomalies as per their urgency. So there are some that are life-threatening emergencies like intestinal obstruction, especially with volvulus or intestinal atrasias, malrotations, necrotizing enterocolitis with perforation peritonitis. Then tracheoesophageal fistula or esophageal atrasia. Incarcerated hernias are also common in newborn babies. Then there are some semi-emergencies like congenital diaphragmatic hernia and abdominal wall defect. Why semi-emergency? Because these patients initially require to be stabilized, and then we can take them up for surgeries after 24 to 48 hours. And then there are congenital anomalies which are treated later at an appropriate timeline, like non-urgent neurological anomalies, hypospadias, PUJ obstruction, posterior urethral valves, cleft lip, cleft palate, which initially require only a feeding tube to be inserted and can be repaired at a later stage. Then definitive surgery for anolectal malformation, which initially has been diverted. Then there are definitive surgeries for ambiguous genitalia, undescended testes, which can be done at a later date. So initially, prenatal screening is very important. So antenatal ultrasounds, maternal markers, and amniocentesis give us an initial diagnosis that this baby may have an anomaly at birth. And postnatal assessment, initially, I would like to stress on this that comprehensive clinical evaluation is very important once the baby is born. So, in vital sign monitoring and a complete physical examination of the newborn baby is very important to diagnose a congenital anomaly, especially structural anomalies. Once these two have told us that there may be some congenital anomaly, then we can go ahead with genetic testing and advanced imaging. So this is one chart that I want everyone to have a look at. This is head to toe assessment of a newborn baby. Once the baby is stabilized, a complete head-to-toe assessment is very important to diagnose any structural congenital anomaly. These include all parts of the body, so skin, head, eyes, mouth, all the way up to ambiguous genitalia, anus, hip, back, spine. As you can see in this, each of these regions have certain anomalies that can be diagnosed by just having a look at the baby. So cleft lip, cleft palate, there may be jaundice, which is indicative at birth. There may be a palpable lump in the abdomen, and especially that are missed or absent anal opening, a hypospadias. These can be observed by just a thorough clinical examination of the baby. Now, what are the red flags for a neonate? The red flags which indicate surgical intervention may be required. These are 7 that I have come up. Feeding issues, abnormal abdomen, delayed meconium passage, visible abnormalities over the body, respiratory distress, unstable vital signs, and any abnormal palpable lump or swelling. Feeding difficulty. So, any baby who has poor feeding or failure to thrive has persistent vomiting, bilious or non-bilious, especially projectile vomiting. All these indicate towards a surgical cause. Bilious vomiting may be intestinal obstruction, may be small intestinal atresia or malrotation, meconium ileus. Non-bilious vomiting can be seen in esophageal atresia or pyloric stenosis, and sometimes these babies may present with drooling, which shows may be because of tracheoesophageal fistula. Then abnormal abdomen. Any newborn baby with a distended, shiny abdomen with visible dilated veins, visible bowel loops, or a palpable mass, or a groin swelling which has erythema, may be tender. All these point towards surgical cause, and we need to further investigate. Then delayed or absent meconium passage. Failure to pass stools within the first 24 to 48 hours of life, or passage of pellets or ribbon-like stools need to be further investigated. The potential causes for this could be a Hirschsprung disease, especially long segment Hirschsprung disease, which presents to us early in neonatal age group. There may be a intestinal atresia. Medical causes also are there, which also need to be investigated, like hypothyroidism or cystic fibrosis. Then respiratory distress, persistent respiratory distress, not responding to the usual initial treatment. Maybe there is a congenital diaphragmatic hernia. These may be associated with a scaphoid abdomen, may not be associated. These babies need to be further investigated. Invisible structural anomalies over the body of the baby, like abdominal wall defect, a spinal defect, a limb defect, a craniofacial abnormality. All these indicate a congenital anomaly like omphalocele gastroschisis. Absent anal opening or abnormal anal opening indicate towards an anorectal malformation. Then any baby who comes with persistent acidosis, lethargy, hypotension, without any obvious infectious cause, especially low birth weight babies, preterm babies, these we need to keep necrotizing enterocolitis with perforation in our mind, and we need to give in these babies require an urgent surgical intervention. So we always need to monitor the subtle signs like persistent jaundice, failure to thrive, any syndromic associations. So any baby who has to undergo a neonatal surgery, we need to first stabilize the baby. So we need to optimize the oxygenation, maintain the hemodynamics, give proper nutrition. If we cannot achieve enteral feeding, then we need to implement IV fluids, start early parenteral nutrition for the baby. And some conditions which require specific treatment, like in case of omphalocele or gastrocele, the exposed organs need to be properly covered, need to be properly dressed to avoid third space loss. We need to manage pulmonary hypertension in CDH patients. So once the baby has undergone neonatal surgery, very important to give a good post-operative care. These babies are very fragile in the post-operative period, and we need to give them proper nutritional support, respiratory support, as well as to manage the post-operative feeding, achieve early feeding, and we manage as per the post-operative complications. What are the advances in neonatal surgery? There have been a lot of recent advances in neonatal surgery. Many places in India have started doing fetal interventions, though for a very few causes like spina bifida or tracheoesophageal fistula. But we do have these fetal interventions started in our country. Then newborn babies also have the opportunity to undergo minimal invasive surgeries like thoracoscopic surgeries, laparoscopic surgeries, and robotic surgeries.
Dr. Ashwini?
Yeah.
I think your time is getting up. Huh?
Yeah,
Just
I'm done.
wait.
I'm done.
Okay.
Other advances like ECMO 3D printing have also improved the outcomes in infants with complex anomalies. So take home message, what I would like to give today is keep an eye open for syndromic associations and any visible structural defects. Monitor all subtle signs, and any deviation from normal progress indicates towards something going wrong with the baby. Early and timely surgical references. So your vigilance and quick action are invaluable in ensuring the best outcomes for these fragile patients. And together with our shared expertise, we can give every neonate the best possible start to life. Thank you.
Yeah, thank you for that excellent presentation. Very flawless, calm, quiet, very good, excellent, very well done, Dr. Ashwin. Can I request our expert faculty, Dr. Rasik Shah sir, to give your expert comment on the specific topic? Dr. Rasik Shah sir.
Yeah, so Ashwini has presented very well. I think as such, there are no expert any adverse remark as such, except that maybe the robotics in newborn is not easy to do it, and most of the people will do probably minimal access surgery wherever indicated. But otherwise, I think it was very well covered. Pediatric surgeon and neonatologists, I think they have to team together to take care of all pediatric surgical diseases. Without good care in the NICU, the results of newborn surgeries will not be good. So I think good NICU is mandatory for all these patients. I'm done with my expert comments. Mandar?
Yeah, that was a very good presentation. Very good presentation. And I think she has covered all the points that we need to talk about. Mainly, I think the message to all the pediatricians is that don't miss any external anomalies. The common things that we see in our practices, undescended testes is missed, hypospadias is missed. So my message to all the pediatricians would be that whenever you see a new male child for the first time, you strip him and check his genitals, because these things are missed very often. But otherwise, the presentation was flawless. Absolutely. Thank you.
Thank you, sir.
Thank you, Mandar sir, for that expert valuable comments. Thank you, Dr. Rasik sir, Dr. Mandar sir. Now let us move to the second topic. I invite Dr. Swati Sulakshane ma'am. She will talk on acute abdominal surgeries in pediatrics. She is also expert pediatric surgeon. Swati is consultant pediatrician at Sulakshane Multi-Speciality Clinic, Aund, Pune. And she is honorary consultant at Ruby Hall Clinic, Jupiter Hospital, Surya Mother and Child Care, Ankur Mother and Child Hospital. And she has done her fellowship in pediatric surgeries, KK Women and Child Hospital, Singapore. Over to you, Dr. Swati.
Good evening, all. I am Dr. Swati Sulakshane. Thank you, MahaIP team, for the opportunity. With the due permission from our experts, I will start my presentation.
Sure, sure, yes.
Can you see my presentation, please?
Yes, seen and full screen also.
Yeah, thank you. So today I will be talking about the acute abdominal pain and surgical conditions in pediatric population. Acute abdominal pain is severe abdominal pain lasting for less than or equal to 5 days. The underlying pathology may be intra-abdominal, thoracic, or systemic. It may require urgent surgical intervention. In majority of the pediatric patients, the abdominal complaints are relatively non-significant, such as constipation or gastroenteritis. But it is important to pick up on the cardinal signs that might suggest a more serious underlying disease. Diagnosing abdominal pain in children is a challenging task. The conditions vary up amongst the age groups. Plus, trying to thoroughly evaluate a child in the pain can make the process more challenging. As you can see in the chart, there are multiple etiologies for the abdominal pain. With acute pain, the urgent task of the clinician is to rule out the surgical emergencies. An acute surgical abdomen is characterized by the signs of peritonitis, including tenderness, abdominal wall rigidity, guarding, and absent or diminished bowel sounds. Sometimes it could be hyperperistalsis in intestinal obstruction. Important clues to the diagnosis can be determined by thorough history and physical examination. The onset of pain can provide clues. Events that occur with a discrete abrupt onset of pain are passage of ureteric calculus, perforation of a viscus, or infarction. Gradual onset of pain is common with the infections or inflammatory causes such as appendicitis, occult abscesses, or inflammatory bowel disease. It is essential to differentiate between surgical and non-surgical causes of abdominal pain. Certain signs will give us the hint towards the underlying surgical pathologies. When the pain is severe with a sudden onset, when the pain that interrupts the sleep of the child, when there is gross abdominal distension with bilious vomiting, especially in cases of intestinal obstruction, patient breathing in pain, especially in ureteric calculus or intestinal obstruction. There could be guarding rigidity, which could be focal or diffuse, and the patient is generally lying very still or in a typical posture in case of peritonitis. Rebound tenderness, very specific about the appendicitis. Absent or tinkling bowel sounds in case of ascites. When the child is in sepsis, hypotension, tachycardia. Jaundice in case of underlying biliary pathologies, hematemesis. Life-threatening causes of acute abdominal pain. As Dr. Ashwini explained to us, less than 2 years, the main abdominal pain pathologies are related to the congenital anomalies, commonest being malrotation and volvulus band obstruction. Intersusception as we start weaning the child, incarcerated hernias, femoral, umbilical, or inguinal hernias. When the child is about 1 month of age, we can see congenital hypertrophic pyloric stenosis. Very rare, Hirschsprung's disease definitely. Very rarely appendicitis and abdominal tumors. In the age group of 2 to 5 years, the incidences of intersusception go on decreasing and incidence of appendicitis goes on increasing. There could be incarcerated femoral, inguinal, or umbilical hernias. Meckel's diverticulum generally is asymptomatic, but it becomes symptomatic when it is goes in antisusception or there is perforation leading to the peritonitis. Obstruction secondary to the prior abdominal surgeries, peritonitis, which could be primary or secondary. In older children, more than 6 years, the incidences of appendicitis is more. There could be megacolon in untreated cases of the Hirschsprung's disease, peritonitis, pancreatitis, and peptic ulcer disease with or without peritonitis. Very rarely, aortic aneurysm and acute fulminant hepatitis. The characteristic of abdominal pain can give us a clue about the pathology. In intestinal obstruction, the onset of the pain is acute or gradual. The pain is located initially in the periumbilical area or maybe in the lower abdomen. It is referred to the back because of the mesenteric pulling. The quality of the pain is typical colicky. The child will always present with distension of the abdomen, obstipation, biliary vomiting, and hyperperistalsis. In appendicitis, as we normally see, the onset of the pain is acute. The pain to start with is periumbilical, and then it localizes to the right iliac fossa or classical McBurney's point. The pain could be referred to back in case of retrocecal appendicitis, or if the appendix is pelvic, then child may present with tenesmus. The pain is usually sharp. It is associated with nausea, vomiting, local tenderness, fever. The child comes with a typical flexed posture. Mucus diverticulum, as I told earlier, it is generally asymptomatic, but when it undergoes intussusception or it undergoes perforation, then we can have presentation like intussusception, and then on surgical, when we go for the surgery, we can find mucus diverticulum there. So it is associated with hematochezia. Intussusception, the pain is acute in onset. It is periumbilical. The patient typically comes in the guarded position with knees pulled up, and there could be recurrent jelly stools. In ureteric calculus or urolithiasis, the acute pain is acute in onset. It starts in the back and then it is referred to the groin. It is a severe colicky pain. The child will present with persistent vomiting and hematuria maybe. In pyelonephritis or any intra-abdominal abscess, there will be acute or sudden onset of the pain. It will be localized to the, site of the abscess, or in case of pyelonephritis, it will be located in the back. The pain is always dull to sharp, and it will be always preceded with the fever. Cholecystitis and cholelithiasis is rare in pediatric population, but cases are still noted. In that case, pain is acute. It is generally located in the right upper quadrant. The pain may refer to the right shoulder, and it is generally severe and colicky pain. Since it is common in patients with hemolytic anemia, the child may or may not present with jaundice. There will be nausea, vomiting, and fever to be associated. In pancreatitis, the pain is generally acute. To start with, it is in the epigastric or hypogastric area. It is generally referred to the back. The pain is constant, sharp, and it is associated with nausea, vomiting, and marked tenderness in the abdomen. Once the child presents in ER with severe pain in the abdomen, first step which is important is stabilizing the child. So as per our ABC protocol, assess the airway, see for the oxygen saturation. If necessary, start with the oxygen. Establish the IV cannula with wide bore cannula. Assess the hydration, correct the hydration. We may start with IV antibiotics, colloids as per the hydration of the child. We may have to give the IV bolus. In case of obstruction and distension of abdomen, we have to decompress the bowel by putting the nasogastric tube. For continuous monitoring, we may have to insert the Foley's catheter. Once the child is stabilized, then we go ahead with the investigations. Laboratory tests should include CBC, CRP, electrolytes, creatinine, LFT, amylase lipase in suspected cases of pancreatitis, PT-INR, blood sugar levels, urine analysis, stool tests if necessary, abdominal X-ray in standing position. If this patient is not able to stand, then upright X-ray is necessary. In intestinal obstruction, the X-ray will show multiple air fluid levels, pneumoperitoneum or gas under diaphragm in case of perforated bowel, groundless appearance in case of ascites. Sonography of the abdomen and pelvis is the investigation of the choice. 95% cases of the surgical pathology can be diagnosed by sonography. We should not miss out on scrotal Doppler, as testicular torsion, obstructed inguinal or femoral hernia should be treated as early as possible. Sonography is diagnostic as well as therapeutic in cases of intussusception. Pneumatic hydrostatic reduction can be planned, and it can avoid the surgery. When sonography is inconclusive, then we can proceed with CT abdomen and pelvis with IV or oral contrast as per the requirement. So let us go through common conditions that we see in our day-to-day practices. Appendicitis accounts for about 25 to 40% of admissions for abdominal pain. The three most predictive clinical features of appendicitis are grade of fever, guarding, and leukocytosis. First and foremost important thing is to stabilize the patient. Then we proceed with laparoscopic appendicectomy. In 99% of the cases, the appendicectomy can be done in by laparoscopic ways. Very rarely, we have to convert it to open. Interval appendicectomy in case if the patient is not stable, appendicular lump is formed. Then we do interval appendicectomy after 6 weeks. Second most common abdominal pathology that we see is intussusception. The intussusception is the inversion of the bowel upon itself, secondary to a lead point. Peak incidence is seen in 3 to 12 months old infants, especially when we start the weaning. Child with intussusception presents with pain, which is severe with asymptomatic intervals. There is palpable sausage-shaped mass, typical red currant jelly stools. The treatment of choice in intussusception is nowadays pneumatic or hydrostatic reduction. If it fails, then we go ahead definitely with laparoscopic, SOS open reduction, very rarely hemicolectomy.
Dr. Swati, is it time to wind up? Be a little quick. Okay.
Okay, ma'am. Yeah. Third most common is abdominal trauma. Abdominal trauma may cause hemorrhage, laceration of the solid organs, bowel perforation, organ ischemia from the vascular injury, intramural hematoma. Blunt abdominal trauma is more common than the penetrating injury. Typical mechanisms of trauma include motor vehicle accidents, falling down, and child abuse. After the surgery, the post-operative management is very important. So monitoring vitals, hydration, abdominal girth every 6 hours is important. IV antibiotics, fluids, colloids, analgesics as per the requirement to stabilize the child as early as possible. Uh, thinking of discussing about the nutrition, gradual reintroduction of the feeds as per the tolerance of the child. If the patient is very sick or in sepsis, sometimes we have to consider total parenteral nutrition. For early recovery of the child, we have to watch for early complications, which are fever, bleeding, sepsis and shock, anastomotic leak, wound infection, and wound dehiscence. Sometimes delayed complications like obstruction and long-term functional issues can be dangerous, but that can be managed later. So to conclude, the key points in managing the abdominal pains is to determine if the abdominal pain is acute or chronic, if the abdomen is acute or surgical, or it is benign, and or the red flags present. Acute abdomen in pediatrics requires prompt evaluation and management. A thorough history, physical examination, and diagnostic tests are essential for accurate diagnosis. Advanced minimal techniques, improved anesthesia, and pain management has enhanced the recovery process. Do not hesitate to keep the multidisciplinary approaches.
Can I ask others to mute?
Thank you.
Yeah. Okay, Dr. Swati, that was an excellent presentation covering everything. Yes, Dr. Grivita, please take over.
May I request Dr. Rasik Shah sir, our expert, to kindly comment on Dr. Swati's
So acute abdomen, it's a very difficult subject to cover in 10 minutes. It is, or rather, next to impossible. Probably it will take few days to cover, but she has covered most of the things. There are a few things which I would like everyone to remember. In any patients, basically, if you are, many patients are investigated by somebody else and then you will be seeing. So always check the date on the report. You know, sometimes the sonography may be done 5 days back, and you may think it is appendicitis and the report may be normal. So always check the date on the report. The second thing is sometimes pain continues in spite of all investigations which are normal, pain in right iliac fossa, then it is acute appendicitis unless proved otherwise. And we have operated quite a few patients whose investigation, including CT, will not show classical appendicitis, but this patient will respond to the surgery. Third, you cannot forget constipation is a cause of acute on chronic or acute abdomen. They can present in any way. So always remember about that. And in intussusception, most of the time you can do hydrostatic reduction. Occasionally, if you can't do hydrostatic reduction, then it basically means that there is underlying gangrene and we may not be able to even reduce it operative and they may need resection. Of course, that is technical part just to tell you people. So apart from this, and in appendicitis, always remember it is pain, vomiting, fever. This is the triad. It starts with pain, which she has explained you well. Vomiting, generally non-bilious to start with, bilious only if there is perforation or ileus, and fever, which is mild grade. If it perforates, then everything is exaggerated. So pain, vomiting, fever. If it starts with fever, it is not appendicitis. Pain, vomiting, fever. If it is fever and then pain, then it is something else which can be investigated or discussed. Yeah, please go ahead. These are my few comments.
Sir, for this. Thank you so much for this valuable tip. Manar sir, any comments from your side?
Yeah, that was a nice presentation. She has covered everything. I think abdominal pain is one of the commonest OPDs that we see in our practice, and most of them are googlies. Very often they cannot be. They need a lot of investigations, and there is a small group of patients I have seen who are functional and they keep coming back with abdominal pain, and there is nothing wrong with them. I thank you, Rasik, for telling me that we can go ahead and do an appendicectomy in them, and many of them come back with pain and they'll get relieved. But I have generally not done an appendicectomy unless there is ultrasound or some evidence of appendicitis. But I think I will do it next time because I do get a lot of functional patients who just fake abdominal pain to not go to school or not go to exams or whatever. And they're such good actors that you get fooled completely by them.
I
Uh,
completely agree with that, Mandar, that there is a group of patients who you can make out that they are malingering. And I mean, first time I got what do you call, got into it, I operated, but she kept on coming after that. And then if you go into the history today, I can make out this guy is malingering, I will not touch. Because you don't want to have headache in post-op patient, means they will keep on coming harassing you. So most of the time with little bit of history and examination, you can make out that this guy is malingering, this girl, or usually the age group is 8 to 10, 11 years, and that this is the age group where you have to be little more vigilant to identify these patients.
Constipation is
Sir,
a
just
very underrated cause of abdominal pain I've seen. It is very, very common, constipation, and abdominal pain because of constipation is extremely common. It has to be tackled, basically.
just a small comment. Most of us gain an abdominal pain which comes recurrently. Probably end up with an abdominal USG, and we see mesenteric lymphadenitis. So, how significant is this for us? What would be your comment on this?
So mesenteric adenitis can be the cause of fever, I mean cause of pain in abdomen. Generally, it will be associated with some viral infection. Now, it can be treated conservatively unless there are, if they keep on coming back with like what Mandar is saying, and if there is mesenteric adenitis, that is indirect evidence of some subacute or chronic appendicitis. There is one paper published from Hyderabad, Nagarjun Reddy group. Of course, that's in adult. That mesenteric adenitis presenting as a chronic appendicitis. We get rid of appendix and it settles down. So if this patient keeps on coming back with pain in right iliac fossa or umbilical area, and at some point you may discuss with them and you do diagnostic laparoscopy and do the surgery. The reason is like, I mean, I have one video which I recently presented where there are many other causes of abdominal pain which can be missed out by all the investigations, which includes Meckel's, which includes band from Meckel's to umbilical area. It includes adhesions. It includes a lot of things which can be missed out. So if pain continues and if it is significant, associated symptoms 110%, one has to go in, do diagnostic laparoscopy, and make sure that there is nothing else. Along with that, you get rid of appendix, and most of this patient will settle down. Most of them is 98%, I would say. 1 or 2% can harass you even after that. Yeah, please,
Thank you,
Mandar.
sir.
Yeah, I agree with you, but I think that practically every ultrasound report shows some amount of mesenteric lymphadenopathy. And I don't think we should pay too much attention to that unless the size of the node is more than 2 centimeters. That is definitely significant. And then that patient definitely needs to be investigated by laparoscopy or by whatever. But small half centimeter, 1 centimeter nodes all over the abdomen, I don't think I would pay much attention to that because every ultrasound report shows some mesenteric adenitis.
Yeah, this is not first attack. If they keep on coming back with
Yeah.
pain in abdomen, then at some point you will have to take a call and probably do diagnostic laparoscopy. I mean,
Thank you, sir.
what I'll do, I'll upload the video which we just had on that group, and if you people want, you can just circulate that.
Okay, that will be
Yes,
good.
thank you.
Yes,
Thank you so much.
yes.
Moving on next, now I request Dr. Prashant Badade from IIP Nasik. The topic being pediatric solid tumor surgeries. Over to you, sir. Dr. Prashant.
Hello.
Hello. So shall I share the presentation?
Hello.
Yes, yes,
Yes, yes.
Yes.
yes, ma'am. Dr. Prashant, please go ahead.
Yes. Sir, good evening, Mandar Singh Rasik Shah, sir, and good evening, all the dignitaries of the Maha-IP Society. Today, I will be presenting topic on pediatric solid tumors. Am I audible?
Yes, you are audible.
Yes, sir, you're
Hello.
audible. Yeah, you're
Yeah.
audible, sir.
Oh,
You may please continue.
okay. So, in pediatric solid tumors, most commonly we come across neuroblastoma, LIMS tumor, rhabdomyosarcoma, and teratomas. Now we will start with the neuroblastoma. Basically, neuroblastoma is a most common solid extracranial tumor. It arises from sympathetic nervous system, and it is a heterogeneous disease to begin with. Depending on its location, pathology, and biology, it has different features and different presentations. And its therapy is driven by Children's Oncology Group research protocols. It
Sir, your video is not seen if you want to. Please continue.
Prashant sir, kindly unmute yourself. Prashant sir, are you there?
Hello.
Yes.
Prashant sir, we
Yes.
can't see you
Hello.
also, can't hear you also. Yes. Unmute yourself.
Hello.
Dr.
Yeah.
Prashant, unmute.
Yes. Yes. I have unmuted.
Okay.
Sir, you're audible.
Hello.
You may please continue. Sir, you may please continue. You're audible.
Yes, okay. And depending on its site of presentation, we will get the different features. Most common site is abdomen. So the site of origin is sympathetic ganglion. Uh,
We can't hear you, Prashant sir.
Hello.
Prashant,
Most common site is adrenal medulla. Hello.
प्रशांत तुझा व्हिडिओ ऑफ कर आणि मग बोल कंटिन्यू कर. आवाज येतोय
Common
का
site
तुला?
is adrenal. Other common sites are. हो मला येतोय आवाज.
हा मग तुझा व्हिडिओ ऑफ ठेव आणि
Hello.
कंटिन्यू कर. हा आणि स्लाइड चेंजच्या वेळी
ऑफ
मॅडमांना सांग
केलाय, ऑफ
स्लाइड चेंज
केलाय.
असं.
अच्छा, ओके. मॅम चेंज. Yes, next, 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 next. Most common site is adrenal medulla, and the other second most common site is sympathetic chain, sympathetic ganglion, and para-aortic bodies, that is pelvic organ of Zuckerkandl, may also give rise to this tumor. The clinical presentation depends on the site of presentation. Most children are affected in less than 2 years, less than 4 years, and peak is 2 years. Constitutive symptoms because of chemokine release are found. Then primary tumor may give rise to tumor compression, tumor lysis, and hemorrhage in the tumor. Metastasis to the bone marrow, bones. Catecholamine release can cause headache, flushing, and sweating, hypertension in children because of renovascular causes, and sometimes paraneoplastic syndrome can also occur because of this catecholamine release. Yes, this in this picture we can see the or intraorbital extension of the tumor. Below picture shows the skin metastasis because of neuroblastoma, and the CT picture of the intracranial and intraorbital extension of the tumor. Next slide. So basically, evaluation is by imaging studies and laboratory tests. In lab test, we will assess CBC, renal function test, liver function test, electrolytes. Main diagnostic markers are catecholamine metabolites, that is human HV and VMA, vanil manelic acid, and they are elevated in urine in most of the 90 to 95% of the patients. HV and VMA levels are useful for diagnosis as well as monitoring of the response of the patient. And indicators of tumor burden are LDH, ferritin, NAC. They are used for prognosis as well as response to the treatment. Now, imaging is very important in neuroblastoma patients. The IDRF is the image defined risk factors. These are important for staging of the neuroblastoma disease. So imaging is mandatory to assess the loco-regional disease extent. We will need CT or MRI for cross-sectional imaging. For metastatic evaluation, we will need chest X-ray and iodine 123 MIBG scan. And to assess the response to neoadjuvant therapy, we will again need CT or MRI for localized disease and MIBG PET scan for high risk or metastatic disease. Most common investigations in our routine practice we will do is CT abdomen. For depending on the suspicion of the metastasis, we may need chest scan, bone scan, and PET CT. And for surveillance, that is post-treatment monitoring, we will need ultrasound or CT or MRI depending on case-to-case basis. There are no clear-cut guidelines for post-treatment surveillance imaging modalities. Now, in next slide, in this CT film, we can see the stipple calcification in the CT of the neuroblastoma patient. This stipple calcification is very specific for neuroblastoma. It is very different from the teratoma or Wilms tumor. And again, in the adjacent picture, we can see the push down, left kidney is pushed down because of this suprarenal mass. This is very specific for the neuroblastoma. Now, there are some differences between neuroblastoma and Wilms tumor on imaging modality, the CT scan. We will see stipple calcification or lymph node with calcification in in neuroblastoma, not in Wilms tumor. Neuroblastoma tumor will displace the kidney inferiorly. It may cross midline, whereas Wilms tumor rarely or never crosses midline, but neuroblastoma may cause midline. Neuroblastoma may involve or encase or displace intraabdominal vessels, and neuroblastoma tumor may have spinal extension, or it will occur as paravertebral mass. So for staging, we have different systems. Two systems are available. International neuroblastoma staging system. It depends on surgicopathologic findings, and INRG, International Neuroblastoma Risk Group. It depends on imaging modalities, imaging finding. Next slide. So International Neuroblastoma Staging System, INSS. Next slide. It depends on the 1, 2, 3, 4. There are 4 stages. In stage 1, disease is localized, and we have completely excised the tumor. There is complete gross excision, and there are no lymph nodes involved. That is stage 1. Stage 2A is disease is localized. There is incomplete gross excision in the surgery, and lymph nodes are negative. 2B is disease is localized, and there are ipsilateral lymph nodes are involved. Stage 3 is unresectable tumor which is crossing midline, or tumor is localized but contralateral lymph nodes are involved. That is stage 3. Stage 4 is metastasis to the lymph nodes, bone marrow, bones, liver, or skin. And 4S, this stage is those stages categories 4, but it has very good prognosis. it involves tumor involving less than 1 year or 18 months of age of the children. Primary. Now, staging according to the International Neuroblastoma Risk Group staging system, INRGSS, it is L1. L1 is disease localized to one body compartment and does not involve vital structures. Now, the vital structures involvement is defined by International Disease this radio IDRF is depending on the radiological finding, it is defined. It is defining the vital structures involvement. Now, L1 is localized to one body compartment but does not involve any vital structure. L2 is loco-regional, means it involves ipsilateral body compartment, and there are presence of one or more image-defined risk factors are present. M is metastasis, and MS is children less than 18 months, or metastasis confined to liver, skin, or bone marrow. It occurs in less than 10% of the patients. Site of the tumor, that is neck, thorax, abdomen, or intraspinal extension, or just infiltration to adjacent organs. If tumor neuroblastoma occurs in the neck, then image-defined risk factors for primary resection of neuroblastoma are tumor encasing major vessels, that is carotid artery or vertebral artery or internal jugular vein, tumor extending to base of skull.
Dr. Prashant sir, your time is getting up.
1 second one. Okay, I will hurry up. Tumor compressing the trachea or tumor encasing the brachial plexus. Tumor arising from the thorax, if it involves subclavian vessels, aorta, or superior vena cava. Tumor compressing trachea. Similarly, have image different risk factors for abdominal, intra-abdominal tumor.
Time is up.
Prashant, finish it. Complete it.
Okay.
Complete
Okay.
it.
Depending on the pathology of the tumor, we have favorable and unfavorable types. Favorable tumor is poorly differentiated neuroblastoma, low mitosis sclerosis index, and less age of the patient less than 1.5 years. Differentiating neuroblastoma, low MKI, this is less than 100. Ganglioneuroblastoma or ganglioneuroma, these are favorable risk factors according to pathological classification. And unfavorable tumors are poorly differentiated neuroblastoma involving 1.5 to 5 years, undifferentiated neuroblastoma, and age more than 5 years. These are the pathological risk factors. Now, treatment for neuroblastoma is for low risk category, low risk neuroblastoma patient. Surgery alone is the mainstay of the treatment. For patients who are in stage 4S, we can simply observe these children without surgery. Additional chemotherapy may be required if there is tumor is unresectable or there is spinal cord compression, and patients not responding to chemo may need radiotherapy. For tumor with intermediate risk, chemotherapy is upfront chemotherapy followed by surgery is required. Chemotherapy for 12 to 24 weeks and followed by surgery when resection is possible. And again, tumor not responding to chemotherapy may require radiotherapy. For starting chemotherapy, we will need surgical biopsy before starting chemotherapy. For tumor of high risk category, we will need aggressive multimodal approach, which involves induction chemotherapy followed by local control of the disease by surgery plus radiation, and after that high dose chemotherapy plus stem cell rescue therapy, and immunotherapy as a maintenance therapy will be required for these high risk tumors. Now, for assessing the response evaluation of this neuroblastoma, international neuroblastoma response evaluation criteria have been defined, which tell us which tumors are which tumors give complete response, good partial response, mixed response, no response, or progressive disease. So criteria are defined according to these
Sir, we are
this thing.
already
Role
overshooting
of
time.
surgery.
Sir, Prashant sir, we are already overshooting time.
Okay, I will stop. I will stop.
Uh, may I request Mandar sir to give his expert comments?
I think he's covering most of the stuff that is in neuroblastoma, but actually he could have made it shorter and covered both WIMS and neuroblastoma in the same talk within 10 minutes. But any case, neuroblastoma is a very difficult tumor to treat, and the surgeon plays only a small role of resection. Most of the treatment is given by the chemotherapist and the immunotherapist, etc.
Yeah, so I agree with Bandar. So neuroblastoma is basically chemo and radiation. Surgery, again, it's not mandatory that we need to excise it completely, because sometimes if it is encasing the vessels, we may not be able to excise it completely. And clinically, when they come to us, we can make out, looking at the child, if there is, it has to be differentiated between neuroblastoma versus WIMS. The neuroblastoma kids are generally sick, and WIMS tumor generally they are healthy. And then it is a prolonged course, and it is a multidisciplinary approach which is required for all these tumor. And it is mandatory today that each town and city should have a team which is taking care of these children, because all of that may not be able to go to the big cities. If they come to Mumbai, we have our multidisciplinary team in place. So similarly, I think each town has to work towards getting this done so that we can treat them well. It is a prolonged course, chemo, radiation, surgery. So anything between few months to a year, or sometimes if it is bone marrow required, then it is still, very, very long course. So we are very far away. So if we see the malignancy cure rate in India is just 25 to 30%, we can go up to 80%. So there is a lacune which we need to take care. It is more of philosophical part, so I will not go into that. But yeah, so with that,
So
I
as
over here.
Sir, as a general pediatrician, I would want to know a few highlighted danger signs in these both cases. But high alert signs which should raise an index of suspicion is for us as a general pediatrician. May you please comment on this?
Yeah, so if you have any lump which is palpable in abdomen, if there are any nodules in subcutaneous tissue, then you can think about neuroblastoma. If sometimes they can have bleeding and red panda sign, which can be there with some proptosis. Some bony lesion here and there can be also because of neuroblastoma. So these are some of the things which lymph nodes, if you see them, large lymph nodes, then again it can be Hodgkin's and cancer. So all these are the signs of some kind of tumor or malignancy in children, and it should be investigated thoroughly. And probably the pediatric hemat-oncologist can tell you more about some of the things. But this is in general that there can be a malignancy. Please investigate.
Mandar sir, your comment on this?
I think most of these children with lump in abdomen are diagnosed by, or are they discovered by their mothers when they're giving a bath to the child. They feel the lump, and painless hematuria is a very dangerous sign which should alert you. Painless hematuria in a child to malignancy. But otherwise, with our routine investigative methods, malignancies are very easily diagnosed. So
Thank you, sir. Thank you so much. Moving on next, I call upon Dr. Vidyanand Deshpande, sir, from IIT Chhatrapati Sambhaji Nagar to kindly take over. The topic is congenital hydronephrosis. Over to you, sir.
So very good evening to everyone. The topic I am going to talk about is congenital hydronephrosis. It is actually a very big topic to cover in 10 minutes. It accounts for a big part of pediatric surgical practice. Most of these patients initially present to pediatricians and then they are referred to pediatric surgeons. And since these kids they need multidisciplinary approach, every one of us must have knowledge of medical as well as surgical management. At the outset, I would like to stress that uh, when it comes to handling delicate tissues, your pediatric surgical colleagues are the best surgeons. And since our approach to these patients is different, and also we think about long-term outcome in these patients. Nowadays, most of these patients they are presenting to us antenatally. So, almost 1% of all pregnancies they are diagnosed some hydronephrosis on ultrasound, and then we have to address the parental anxiety. When it comes to the causative factors, the most of these cases they are having spontaneously resolving hydronephrosis, where we need to observe these patients and we just need to reassure the parents. The three main causes of congenital hydronephrosis are pelvic junction obstruction, which accounts for 50 to 60%, followed by vesico-ureteric reflux, and then there are other causes, out of which I would like to touch on posterior urethral valves. So when these patients come to us antenatally, we can grade these patients based on the antero-posterior diameter of the pelvis. There are many grading systems, but the one which we rely mostly is on the size of this pelvic APD. So when it comes to USG, just to clear our differential diagnosis, we also look for laterality and parenchymal thinning, ureteral dilatation, thickness of bladder. These things are to be looked on USG. So I would like to touch the three common causes of congenital hydronephrosis. First is PU junction obstruction. It is a peristaltic segment which impedes the passage of propulsive bolus of urine. Incidence is almost 1 in 5,000 live births. It is commoner in boys, and 65% of these cases are on left side. Most of these patients, they are diagnosed, they are detected prenatally. Some of them present with abdominal mass and some with urinary tract infections. So in patients with all patients with urinary tract infections, we need to thoroughly investigate, and ultrasound of all these patients is must to rule out any structural or surgical cause of hydronephrosis. The USG is basically cornerstone, and the parameters that are to be looked, we have already discussed those parameters. Our main intervention, whether we have to intervene or we have to observe, it depends on this test, that is diuretic renogram. So the commonly used the nuclear molecules are DTPA, MAG3, and EC. So EC has advantage of that it shows both structure as well as function. So nowadays EC is the most preferred nuclear molecule. In these diuretic scans, we look for renal blood flow, differential renal function, then intrarenal transit time, and time taken for radioisotope to be washed out from the pelvic calyceal system. So indications of surgery, this is important because that is when our role comes in. So any symptomatic child, absolute indications are any symptomatic child, and differential function of the affected kidney is below 50%. And if it is above 40%, then we do repeated scans every 6 months, repeated scans, nuclear scans as well as ultrasounds. And on these scans, if there is fall in renal function, then of more than 10%, then the patient needs surgery. And in cases of bilateral PU junction obstruction and solitary kidney, these are the absolute indications. So the type of operation, I would not go in much details in this, but the most favored surgery for all most of the pediatric surgeons is Anderson-Hines dismembered pyeloplasty. It is the gold standard surgery, and it can be done by open technique, by laparoscopic, as well as by robotic technique. Most of the surgeons follow this technique. A few words on poorly functioning kidney. Sometimes on differential function, we see that the function of the affected kidney is less than 10%. Many of the surgeons, especially adult surgeons, they would advise nephrectomy in these patients. But we have observed that many of these patients, after temporary diversion by percutaneous nephrostomy and then following them for 3 to 4 weeks and repeating the scan, we see that there is significant improvement. These are the patients who can be who can undergo pyeloplasty and their kidneys can be preserved. Other patients, they can straight away go for nephrectomy. Now, second condition, that is posterior valves. This is congenital obstruction at the level of prostatomembranous urethra. Again, incidence is 1 in 5,000. It has been classified into 3 types, out of which the type 1 is the most common. In more than 95% we see these kind of valves. So presentation, there are basically 2 types of presentations. One is antenatal, on USG it has been diagnosed, and second is they present slightly maybe in neonatal or in infantile age group with urinary tract infections. Then some patients present with poor urinary stream and dribbling of urine. And some unfortunate kids, they are neglected and ultimately they come to us at the time of renal failure. They are into chronic renal failure. So this is just a picture of posterior urethral valves, how we see it on the cystoscope, and micturating cystourethrogram images, which is the gold standard investigation to diagnose these conditions. This is the again one picture where we have fulgurated the walls. We fulgurate, that means we incise it with electrocurrent at 12 o'clock, 5 o'clock, and 7 o'clock position, and the obstruction is relieved. So when it comes to managing early management, when they are antenatally diagnosed. So after birth, the first thing, if we are sure that it is posterior urethral valves and the patient has palpable bladder, we need to catheterize these patients. We need to start him on prophylactic antibiotics, then confirm diagnosis by MCUG, that is micturating cystourethrogram. We have to stabilize these patients, and then we have to do cystoscopic fulguration of valves or endoscopic incision of valves. Those not diagnosed antenatally, most of the time they come to us in UTI. So after catheterization, we have to treat the UTI, we have to stabilize. Only after UTI has been treated, we do MCUG, because there is risk of migration of infection from bladder into kidneys. So we do it after you have treated the UTI, and then we, once the urine is sterile, we do cystoscopic fulguration of valves. Now, the last topic, that is vasochorotic reflex. As we all know, there are 5 grades, and again, this grading is based on MCUG, which is again gold standard in diagnosing these patients. Vasochorotic reflex can be primary, it can be secondary. In primary vasochorotic reflex, it is an aberration from this normal flap valve, which is there. It is because of oblique course of the ureter as it enters the bladder, and it has there has to be adequate submucosal length of ureter. Whenever these things are not there, the ureter is straightly getting implanted in the bladder, then there is vasochorotic reflex. Secondary reflex may be because of neurogenic bladders, posterior urethral valves, and high pressure bladders. These are some MCUG images where we can see bilateral vasochorotic reflex in most of these images. Almost 90% of grade 1 reflex, they resolve spontaneously. They don't need any intervention, and they just need some observation. And grade 2, as the grade increases, the chance of spontaneous resolution decreases. So an approach to a patient who comes with UTI, this is very important. When it is the first episode and recurrent UTI, first we will focus on first episode. USG has to be done. If it is abnormal, after treating the UTI, we should get MCUG done. And then after 3 months, we can get the DMSA done. Before 3 months, it is not advisable, because the scars that we see, the acute pyelonephritic patches, they can be seen as scars, which will actually recover in these 3 months. And when it comes to recurrent UTI, USG followed by MCU. In all these patients, MCU has to be done after treating the this UTI. So the primary VUR, primary vasochorotic reflex, when should we give antibiotic prophylaxis? That is for grade 1 and 2, antibiotic prophylaxis needs to be given to up to 1 year of age. And then we can wait and observe these kids. If they have recurrent UTI, then these patients, sorry.
Within
Okay.
your time is also getting up. Huh?
Okay, this is the last few slides. So then recurrent UTI, we have to restart the antibiotics. For grade 3 to 5, we used to give antibiotic prophylaxis to up to 5 years of age and consider surgery if there is breakthrough febrile urinary tract infection. So the indications of anti-reflux procedure are breakthrough infection despite prophylactic antibiotics, non-compliance with medical treatment, severe reflux, failure of renal growth on renal ultrasound, new scar formation, deterioration of renal function, reflux in girls at puberty, and reflux with congenital anomalies like uretrosil and diverticuli. The procedure is, it can be sting, it can be intravesical, extravesical, or laparoscopic reimplant. That's it. Thank you.
Thank you. Thank you, Dr. Vintyanan, for that
Thank you so much.
flawless and covering a topic in a less time. Very nice. Can I ask Mandar sir for his expert comments?
I think he has covered everything very well. There's nothing left to say now. All pediatricians should be aware that young adults who present with renal failure are more commonly because of vesico-ureteric reflux in childhood. So there is a huge responsibility on pediatricians to diagnose vesico-ureteric reflux as early as possible, and it is very easy to manage actually. But unfortunately, untreated cases land up with renal failure in young adulthood. That is all I need to say. Otherwise, Vidyanand has covered everything very well.
Rasik
Yeah.
sir?
So Vidyananda is covered very well. There are few points which I will like to add upon. One is today antenatal sonography detects hydronephrosis, and then it continues, and then postnatally we need to investigate. Antenatally, there are few things which one has to remember. If we think there is ongoing damage to the kidney because of PU valves, one may deliver early. Early meaning before, after 33 weeks, one can deliver. Before that, one may do antenatal intervention. So I'll leave it at that because it's a big topic by itself. The second thing one has to remember that after delivery, if we need to do sonography not on day 2, day 3, but day 7, first 7 days the child may be dehydrated, and because of that, the sonography may be normal. So one needs to repeat it on day 7, and then depending upon the findings, we do at 6 to 8 weeks sonography and EC renal scan. And then further, whatever Vidyananda said is all right. And the most important thing which we follow is the AP diameter. And depending upon that, along with the EC renal scan, we will take a call whether it needs to be operated or not. Another very important point Vidyananda stress, which I will again emphasize, that if the function is less than 10%, it does not mean that we need to get rid of kidney. Many of these kidneys we have salvage and function improves from 10 to 40, 50%. So less than 10, 15% in obstructed kidney, if you relieve the obstruction, function will improve. If the function is less than 5%, 10% because of VUR, it is a dysplastic kidney and it will need nephrectomy. But if it is obstructive because of PUJ, VUJ, please correct the obstruction. So these are the few things which you need to remember. Otherwise, he has covered it very well.
Yes, thank you, judges, Dr. Shah sir, Mandar sir, and Dr. Vidyanand. Now, let us come to the very last topic on advances in minimally invasive and specialized surgeries. To give a talk, I invite Dr. Usha Gajbhai ma'am. She's pediatric surgeon from Amravati. Dr. Usha Gajbhai ma'am. Ma'am, are you there?
Yes, ma'am, she is there. Kindly unmute, ma'am. Usha, ma'am.
Please unmute yourself.
Please
Usha.
start sharing. Okay.
Pallavi madam, may you please help madam?
No, it's okay. I'll. Sorry, just getting to it.
Shall I ask Pallavi ma'am to share your presentation, Usha ma'am?
No, I'll do it. It's there actually.
No, ma'am, that presentation is not downloaded at my end.
I'll
There
do
is
it.
some issue.
Share on group.
Yeah, it's starting. Sorry.
Okay.
Just a minute, please.
There is some noise disturbance. What is it, Pallavi ma'am?
Kharkhar is coming.
I think someone's from someone's speaker.
Is it from Usha ma'am's only?
Is it okay now?
No, ma'am. Presentation is not visible.
Okay, sure.
You just open the presentation, then click on the share screen button. There is a button on Zoom, green button.
Yeah.
Just click on that. After clicking on share, there will be windows. Select your presentation.
Yes.
Is it seen?
Yeah, we can see.
Make it full screen.
Can you make it full screen?
Yeah, I'll do it, ma'am.
Yes, please. Thank you.
Ma'am, is already 10:34. We'll wind up in 5 minutes. Okay, you can be little brief also. Okay, we are seen, ma'am.
Okay, thank you.
Great.
Sorry for the delay.
It's okay. It's okay. It's okay.
Good evening, all. It's almost late actually. Today, most of the topics are covered. I'll talk about the. Am I audible properly?
Yes, ma'am. Yes, ma'am. You can be little louder if you can.
Okay. Is it okay now?
Yes, yes, better,
Okay.
better.
So this is about the advances in pediatric surgery. See this. There are a lot of advances happening all around the world, and same thing happening with the pediatric surgery as well. So a lot of investigations are done antenatally, like ultrasound, antenatal ultrasound, 4D 5D pictures, dopplers, all these are done. And after birth also lot of investigations like MRI, cholangiogram, nuclear scans, PET scans, all these are there. So this gives us a early diagnosis, and gives us a chance to do the prompt treatment for these babies, either unborn or after birth. So there can be fetal surgery, there can be a treatment for the children with the surgical problems with the laparoscopy and the robotic surgery, and eventually we can treat the patient safely with less scars and early recovery. So we'll directly go to the laparoscopy. So laparoscopy is widely used in pediatric surgery for many years. We do laparoscopy for many surgeries all over the abdomen, thoracic also. Commonly pediatric surgery cases are appendectomies, hernia repairs, cholecystectomies, nephrectomies, pyeloplasties, gastrostomies, fundoplications, and repair of congenital anomalies like a congenital diaphragmatic hernia, esophageal atresias and the laparoscopic bariatric surgeries in the young adults or adolescent patients where there is a obesity. So this is one of the laparoscopy case where the undescended testis, which is intra-abdominal, is done primarily with a laparoscope, primary orchidopexy in the intra-abdominal testis, undescended testis. This is another case of a pyeloplasty which is done laparoscopically, where the laparoscope is used and the pyeloplasty is done with a minimal access. This is the pelvis which is being opened, and later the dissection of the ureter and the pelvis is done, and then pelvis is anastomosed. Thoracoscopic video assisted surgeries are quite commonly done nowadays for many procedures, like biopsies from the lung for various nodules or tumors, congenital diaphragmatic hernia repair, tracheoesophageal fistula repair, lung lobectomies, and repair of congenital other anomalies like lobar emphysemas and the other CCAMs and the other surgeries. There are lesions like paraspinal tumors which can be removed thoracoscopically, and empyema is the commonest thing which is done. Robotic surgery is getting access into the India. Da Vinci is the surgical system which is most commonly used in India. It has got three components. This is a console for the surgeon, and in the middle there is a panel where the surgeon can see and the operative people can see, and the last one is where the bluish marks are there. That is a docking system which will eventually work on the patient. The robotic surgery is commonly used for most of the cases of the urology, and pyeloplasty, nephrectomy for the atrophic kidneys, or ureteric reimplantation for the VUR, and the cystoplasty. In general surgery, appendicectomy, cholecystectomy, and fundoplication can also be done. And pediatric oncology, many centers in the India, they are doing tumor resections and the biopsies robotically. So this robotic systems are only available in the metros, not in all the small cities, as it is a very expensive thing. This is one of the robotically assisted diaphragmatic hernia repair, which is done thoracoscopically. I mean, from the thoracic exposure. These are the this is the general robotic assisted surgeries done commonly in the children. Urology we have already discussed. General surgery we have discussed. In general surgery, one of the common surgeries done is cholecystectomy along with the choledochal cyst. And in gynecology, salpingectomy, oophorectomy, ovarian cystectomy, and some of the Mullerian duct excision can be done. What are the advantages of the robotic surgery? There can be there is a lot of precision, and the recovery time after surgery is very much less. It's a minimally invasive approach. Precise tumor removal or resection is possible. Improved accuracy because of the 3D exposure. Reduced surgical trauma. Faster recovery. There is an enhanced dexterity in robotic surgery. Reduced post-operative pain and minimal scarring. There are challenges also because it's a very high cost system. Not everyone can access the robotic surgery, and the treatment is also expensive. and the systems are available only in the metros, as I said earlier. Special considerations for the neonates and the infant, because there is still a learning curve among the surgeons. Very rarely there can be a robotic malfunction, and one of the problem with the robots is there is a no haptic feedback. Fetal surgeries, in the first talk she just touched it. I'll just tell you a little bit more about it. It's an evolving branch throughout the globe and needs a multidisciplinary treatment. The team involves gynecologists, radiologists, pediatric surgeon, counselor, psychologists, pediatricians, anesthetists, and whole lot of OT staff. It's not a one-day treatment. The planning starts when the radiologist sees some anomaly, and then they do the all evaluation investigations, and then meetings and good planning, and then only it is done. Very few centers are doing in India, but still people are trying it. It's a radiologists, they are getting a lot of training for the fetal anomalies, and they are because of that we get lot of babies, unborn babies with congenital anomalies, and this gives us a chance to treat the baby intrauterine. There are three types of fetal surgeries. One is a open fetal surgery, involves making an incision on the uterus to access the fetus, and used for the conditions like a spina bifida and certain heart defects. Minimally invasive fetoscopic surgery is the second one, where the small incision is used guided by the fetoscope and the ultrasonography, commonly used for the twin transfusion syndrome and the congenital diaphragmatic hernia. The percutaneous fetal therapy involves a catheter under the continuous ultrasound guidance, used for the conditions like bladder outlet obstruction, where the shunt is put inside the bladder to drain the urine to relieve the bladder outlet obstruction. There are challenges in the fetoscopy or a fetal surgery. It's a very high risk treatment and technically very complex. Potential complications are there for both mother and the unborn fetus. Limited availability of the specialized centers and the trained professionals are there, so it's a very challenging thing. AI is also making some useful things in pediatric surgery, as it is happening all over the medical treatment or a medical faculty. The pediatric surgeons, they are also doing the endoscopic treatments, lasers, PCNL, and ureteroscopic treatment of the various diseases. These are the two videos I am showing side by side. One is the utricle, urethral utricle, which is being fulgurated, and this is the valve which is fulgurated. Both are done by lasers. So these are the things. Actually we are really late for our talk, so these are the things which are there used by the pediatric surgeons. Thank you very much for patient listening.
Yes, thank you, ma'am. We were really curious to know this topic, and thanks for your overview. Can I request Mandar sir for your expert comments?
Well, except for laparoscopic surgery, I have no experience at all in robotics and fetal surgery. But laparoscopic surgery is now routinely done everywhere, and it makes a huge difference in wound healing, in the recovery of the patient, and from all points of view. So I think laparoscopy is slowly going to replace open surgery over a period of time. Robotics is very expensive. It has its advantages, but at least in a district place like ours, I don't know how many patients can really afford it. And fetal surgery is something. It's a dream-like project. I don't know. It's
Yes.
beyond me.
Yeah. Dr. Shah sir, you want to say
Yeah,
something?
so she has
Usha ma'am, can you stop sharing?
Yes, yes, ma'am.
Usha has given a good overview of what is happening in the pediatric surgery or in general surgery. So few things which I will like to summarize. Today, most of the things can be done using minimal access pediatric surgery in any system. I will not go into details. He has given rough idea of everything. Second is between robotics and minimal access pediatric surgery. What today we feel is it is the robotic is very good for surgeon because he will be comfortable in his position. The same thing is not translated 100% to patient because in robotics, the size of incisions are 8 to 12 millimeter, and usually there are four of them. In minimal access pediatric surgery, generally it is 5 scope and 3 instruments. The surgeon may have some difficulties. Apart from that, cost and other things has been already told by Usha as well as Mandar. So that difference between robotics and minimal access pediatric surgery is across available in most of the places. Recurring cost is minimum, so I think that is going to stay. Robotic will be reserved for something which is very difficult to do it, something like sleeve resection of bronchus and something like which is not easily available or easily doable in using thoracoscopic surgery. The last part which I will like to tell is on the fetal surgery. We have done few in SRCC Children's Hospital along with Dr. Chandar Lula, who is the radiologist. So we have done, I think, 3 or 4 TTTS syndrome, where we have ablated the abnormal communication with the vessels, and one PU valves which we had done at 22 weeks, and it was the fetoscopy was done and valves were fulgurated. The patient was delivered around 35, 36 weeks, and he is doing well with create of now it is almost 3 years post surgery. I mean, postnatal 2 or 3 years, and the create last was around 0.38. So a lot of things are going to happen as the economy of India improves. All this, what is not accessible today, will be accessible tomorrow. So the young generation, pediatric surgeon and young pediatricians will see that more often than those who are expert today. So that is what I would say. Yeah, so all this is going to come in, and we need to embrace them. We need to learn about them and take it forward.
I'd like to interrupt here by saying that Dr. Rasik Shah was the pioneer of laparoscopic surgery in Bombay. And he has not only started laparoscopic surgery, but he has also passed on his skills to a huge number of students who are now practicing laparoscopic surgery all over India. So, big shout out to him.
Thank you.
So
Thank
we
you.
all are lucky to have you here, sir. Thank you so much.
Thank you.
Thank
Thank you.
you, Dr. Usha ma'am, Mandar sir,
Thank
Rasik
you.
sir. It
Thank
was
you.
excellent. Usually each patient will wait for surgery should get over, but I don't know. Today we are feeling that discussion and learning should keep going on. So that excellent discussion. Now it's the time for vote of thanks. As we conclude this academic session, we extend our heartfelt gratitude to everyone who all have enthusiastically joined through Zoom and YouTube as well. Our sincere thanks and gratitude towards respected Dr. Rasiksha sir and Mandar Vaidya sir for your valuable inputs and point of care who has guided our speakers also in forming their presentations. That means a lot to us. Thank you so much, both of you, being our expert faculties today. Heartiest congratulations to all the speakers. Actually, over short period of time, all five speakers done so well. They were preparing till yesterday. One of the speakers presented his slide, made his slides today itself, and that's a great achievement for us. And we are so happy for everyone. You all have done very well. Congratulations, all the speakers. Thanks, Dr. Ram Gopal Chejara sir, for always supporting us And whenever minute problem also comes, sir is there to say yes and push us to do best out of each session. We really appreciate, and I declare on this platform, you are the best president in 2024. We are very happy for you, sir. And nothing much to say about Amol Pawar, sir, who has connected to each and every pediatrician over the globe. And nationally, he is such a popular figure and is a versatile person. Lot to learn from you, sir. Your good connectivity, guidance, and your leadership is hats off to your skills. And we are so fortunate to be your the committee chairperson. Thank you so much for guiding us, sir. Thanks, dear Dr. Grivita Raikar, being my co-chairperson and managing each and every program, monthly program we are arranging, and she is a very good support for us. Today she is in travel, so little connectivity was problem. Thank you, Grivita, so much. Thanks, Dr. Amruta
Thank you
Baviskar,
so much, madam.
Women Committee, yes, Women Committee convener, Dr. Amruta Baviskar, and all my Women Committee office bearers
Thank you
all
so
over
much, madam,
Maharashtra.
for the cover up also.
Yes. Thank you so much. Thanks, Bhavesh sir, for being the scientific support. Thanks, the most pillar entire year, Dr. Pallavi Dharmadhikari, madam. Nothing person I've seen like Pallavi. She's on toes anytime to do anything, whatever she says. She only says, ma'am, I'm there. Ma'am, I'm there. Thank you, Pallavi, ma'am. Thank you. God bless you. Thanks, everyone who all supported us in 2024, and let us keep learning and keep connected rest of the academic journey with MahaIP and Central IIP as well, and take very good care of yourself and your patients. And happy new year 2025 to everyone. Here I declare the session is over. Thank you so much.
Thank you.
Madam,
Thank you.
I want to add one more thing. A special thank to Amol Pawar for being the secretary. See, we had done a lot of online sessions, and every session had this MMC point. We have spent almost 50% our budget on MMC point, but nobody knows how these the procedure has to be followed to get this MMC point. Here, Amol comes every time applying for a MMC point 15 days before, getting that point, then reminding the MMC observer to come online. It's hats off to you, Amol. In spite of being busy in the CIP, one thing I will accept that he has never compromised his work as a secretary of Maharashtra IP. He had never given that importance to the CIP. Every time for every work, yes sir, me karto hai. Even थोड़ा delay हुआ तो भी sir भी करते हैं. And I have seen him doing the work till the last moment. So thanks, Amol.
100% agree, sir. And one more good point, Ram Gopal sir also added to MahaIP Zoom platform. He has raised the number of 100 from 500. And once again, we'll remind one session we had 450 delegates join on Zoom. That's the highest thing. Today being a holiday, maybe like Christmas season, we have like around 150, but we are really happy. Thank you so much, and
Thanks,
feeling so
everyone.
accomplished.
And so, Sanjay sir has also
Thank
consented
you.
to keep it the package same as like this
Great.
year 500 this thing 500 capacity.
After seeing the last month's meetings, virtual meetings, then I came to know that there are n number of people who are joining virtual. So I thought the Ram Gopal sir's vision is proper. So I thought the same number should be continued.
Great. Thank you.
Thank you.
Actually, I wanted to ask delegates whether there are any question for delegates, but then vote of thanks came in. Are there any questions?
I don't think so. In the chat box also, questions were not
no
there.
question was there, yes.
Yeah. Okay.
Thank you.
Okay,
And
thank you.
thanks to Dr. Vishal Raut, our digital wizard, because for these catchy flyers all around the year. So thank you, Dr. Vishal, for your time and efforts in making these all academic programs successful. with your catchy designs for all the academic flyers. Thank you, Vishal.
Dr. Vishal is just expert in making flyers. He's a wonder person, I think, Dr. Vishal. Thank you so much.
We'll take Dr. Matin's comment.
Dr. Matin Shah. Dr. Matin Shah, please.
Matin Shah.
We can have your comments.
Yeah, thank you so much for giving the opportunity actually. And it was excellent session and very well planned event. And I wish all of you happy Christmas and happy New Year. Excellent work done by Dr. Ram sir, Amol sir, and Dr. Bhavesh Mithya sir. And it was excellent working this year. Thank you so much for giving the opportunity. Thank you and good night.
Thank you, Dr. Matin. Thank you.
Thank you.